A normal afternoon outside is shattered in a fraction of a second by a frightened dog. While the physical bite will heal, the saliva introduced into the wound silently triggers a lethal biological countdown inside the body. The stakes of this infection are absolute. Once clinical symptoms of rabies appear, the disease is nearly 100% fatal. This data visualization charts the global epidemiological toll. Rabies claims roughly 59,000 lives every year, heavily concentrated in underserved rural populations across Asia and Africa. And as the highlighted segment shows, 2 out of every 5 victims are children. All mammals can carry the virus, but up to 99% of human cases originate from a single vector, infected dogs. This leaves medical science with a stark paradox. We are fighting an illness with a fatality rate that rounds up to total certainty, yet it is entirely preventable if we respond in time. The initial phase of a rabies infection is known as the incubation period. For 1 to 3 months, the virus sits near the site of the bite, slowly replicating in the muscle tissue without triggering a systemic alarm. Rabies is highly neurotropic. Instead of entering the bloodstream, where white blood cells would easily detect and destroy it, the virus deliberately breaches the outer membrane of peripheral nerve endings. Safe inside the nervous system, it begins an agonizingly slow journey. It crawls upward along the interior track of the nerve fibers, advancing toward the spinal cord. The point of no return occurs the moment the virus reaches the brain. Safe from immune interference, it undergoes explosive replication, flooding the surrounding neural tissue and spreading outward into the salivary glands. This neural takeover produces the clinical features of furious rabies. Patients experience severe neuropathic pain at the bite site, extreme confusion, hallucinations, and hydrophobia, a terrifying, suffocating spasm when attempting to swallow liquids. Once these neurological symptoms manifest, the virus has secured its victory. At this stage, hospitals can only offer palliative care to ease the patient's passing. The race against time is lost. But during that long, quiet incubation window, we have a clear protocol for defense. The immediate counterattack starts at minute 0 with thorough mechanical action, flushing with soap and water for a minimum of 15 minutes to physically wash away the viral load. Medical professionals classify bites based on severity. Single or multiple bites and scratches that draw blood are defined as a Category 3 exposure, which immediately triggers the highest level of emergency protocols. Because the body's adaptive immune system takes weeks to recognize the threat and build its own defenses, doctors deploy rabies immunoglobulin, or RIG. RIG is a concentrated dose of pre-made antibodies. By infiltrating this fluid deep inside and around the wound, doctors can instantly neutralize the virus on site, acting as an emergency brake. These initial measures function as biological stopgaps. By reducing the local viral load and providing immediate temporary neutralization, they keep the infection at bay until the vaccine can trigger a permanent immune response. That definitive treatment is the modern, highly purified cell culture rabies vaccine. This step is called post-exposure prophylaxis, or PEP. By introducing inactivated viral proteins, the vaccine uses the long incubation period to train the patient's own immune system. It teaches the body to hunt down the virus while it is still trapped in the peripheral nerves. To ensure a durable, overwhelming immune response, PEP requires a strict schedule. Patients receive a series of intramuscular injections spaced precisely over 2 to 4 weeks. For individuals facing constant exposure risk, like veterinarians, doctors administer pre-exposure prophylaxis. This pre-trains their immune system, so if they are bitten, they require fewer booster shots and no RIG infiltration. When administered promptly and correctly, PEP has a near 100% success rate. It relies entirely on exploiting the virus's uniquely slow travel speed, turning the pathogen's stealthy incubation into its fatal weakness. The foundation of this treatment dates back to Louis Pasteur's creation of early nerve tissue vaccines in the late 19th century. Science has progressed significantly since then. Today's cell culture vaccines are safe, highly immunogenic, and require smaller doses. The medical science is perfected. The primary hurdle today is ensuring global access. But treating human patients after an attack is entirely reactive. With dogs responsible for 99% of transmissions, stopping the disease requires shifting our focus from the clinic to the streets. Public health organizations employ a One Health approach. This strategy recognizes that human safety is inextricably linked to animal health. By conducting mass dog vaccination campaigns, we interrupt the transmission cycle at its source, ultimately creating a permanent immunological barrier within the global dog population is the most effective way to eliminate the threat of human rabies permanently. This strategy forms the core of an ambitious initiative spearheaded by the World Health Organization to achieve zero human rabies deaths by the year 2030. Hitting that target requires an immense logistical effort. It means expanding access to PEP and RIG in remote, underserved regions, paired with relentless, community-wide dog vaccination programs in endemic areas. For the child bitten in our opening scenario, the prompt application of these protocols means the biological countdown clock has officially stopped. Because of the immediate 15-minute wound washing, the infiltration of RIG, and the full course of the PEP vaccine, the virus never breached the central nervous system. The child remains healthy. Rabies is one of humanity's oldest and deadliest pathogens. Yet through rigorous science and coordinated global action, we possess the tools to ensure no one ever dies from it again.